Hello, everybody. Welcome to this session, this CITES event, which is on the SONAR-Global project. And what we're going to be discussing today is using social science methods to support the prevention and control of infectious diseases in Europe, the results from the SONAR-Global project. We're going to be focusing on the SONAR-Global project, but we really want to broaden the discussion. So we'll not only focus on the SONAR-Global project, we're going to take a broad approach to this session, and we'll be having talks about Europe, but also outside of Europe. Our first speaker is going to talk about activities in Europe in this area, and our first speaker is John Kinsman from ECDC.
Thank you very much, John, and thanks a lot to everybody for coming to this session. It's really a privilege to be here and to have this social science session in the escaide conference. I'm just going to spend a very few minutes talking about social science and the contribution it's made really during the pandemic. And I think I don't have any slides here, so I'm just going to give us a short introduction to the issue here. And basically, I think the overall point to say is that within ECDC and certainly within Europe as a whole, social science is increasingly recognized as an area of key importance in public health. And I think the pandemic has really facilitated this recognition. I think people have realized that you can have a fantastic intervention to control the spread of the virus, whether it's a non-pharmaceutical intervention or whether it's a vaccination or whatever it may be. But unless people are willing to do that, and unless the message to enact this intervention is put across to people into the context in which they understand it, it's not going to happen. And social science is uniquely qualified to sort of present this perspective and allow the interventions to be put forward in a way that is meaningful to people. And I think what we have also seen over the course of the pandemic is an increasing use of social science, both quantitative and qualitative. A number of countries within the EU have been using regular cross-sectional surveys on behavioral issues. And this would be whether it's, for example, adherence to the different measures, whether it's acceptance of the measures, what people think about them, people's perceptions and beliefs and practices regarding vaccination. This is also something that's been happening a lot this year. These have been issues that have been on a cross-sectional basis addressed over the course of the pandemic, and this has allowed decision makers to understand what their populations are thinking about these different interventions, and thereby to implement policies which hopefully apply and are applicable and acceptable to the populations. So there have been these quantitative surveys. A lot of them have followed a model that has been developed by WHO Euro. They have presented a set of questions which different countries have sort of selected from and adapted according to their own settings. A few countries have also used qualitative data to identify particular issues, and that has also helped to put meat on the bones, as it were, of some of the numerical material that we've got through from the survey data. So, but as I said, I think it's quite clear that this has become more and more used over the course of the pandemic. And what I think we saw in the beginning was when people were really trying to understand how to respond to this as a whole, it wasn't always institutionalized, whereby there would be a social scientist in an important position to actually have a contribution to the process. And so it was actually, I know from at least a couple of countries within the EU, it was individual people in the right place at the right time who managed to maneuver themselves into basically into the room where the decisions were being made. So this wasn't necessarily because of sort of a structure in place, but rather it was individuals who did it. Now they're in, now their voices are being heard, and now the contribution of the social science is actually being made within the decision-making process. So this is something which has been a really fantastic achievement from a number of people in a number of different countries. We did some work earlier this year. We published a report in February looking at behavioral insights and the research that's been conducted over the course of the pandemic. And we worked very hard to get information from all the countries within the EU. And it was actually quite difficult to get feedback, to get actually good information from the different countries. And in the end, in spite of quite a lot of work, we only got 10 countries to respond in terms of telling us what they were doing in social science in the pandemic. Now, that doesn't mean that the other 17 countries, or 20 if you also include the EEA, it doesn't mean they're doing nothing. But to me, it does indicate that there is a bit of a gap, perhaps, in some of these other countries in terms of getting the information to the right people, of the people at the top understanding that these things are going on, that social science is actually happening. So there are issues there in terms of it's not all the countries that have social science that's working well. And in particular, we found that there is a gap down in the Central and Eastern European side. There is much more capacity, it would seem, at face value, in the Western and Northern European countries than in the East and the Central European countries. Now, that's not to say there's nothing over in the East and Central side, but it would appear to be less so. And so this is an area which we think would be a gap that we really, really need to be looking for to try and fill in terms of capacity building and supporting in these areas. There is a community of practice. There are people who know each other, and the SONAR-Global project is one such example. People, social scientists who are from different countries working together, but it would be very much a product, an outcome of this meeting and also future meetings if we can strengthen that community of practice and bring more people into it. But I think it's absolutely critical that as we now move towards what we all hope will be the end of the acute phase of the pandemic, that the lessons learned from this are really institutionalized now. We all know that memories are short. We know that within 6 months or 9 months, there could be another crisis that decision makers are having to deal with, and that the pandemic will, to some extent, have receded in people's memories. And so these lessons that we have learned, including implementing social science and bringing this to the attention of decision makers, it really needs to be put in place now before the memories are lost. It also, once the pandemic acute phase is over, we need to keep it going. You can't just build these things up in a second. You need to keep it going so that when the next crisis comes, there is capacity there to be rolled out and used in real time. So we're not once again starting from a standing start. So my main message here is for just to sort of kick off this discussion, within the EU there is fantastic capacity, but there are still gaps. And there is a risk that we could lose some of the momentum that we've gained over the course of the pandemic, and we need to work very hard to try and make sure that that doesn't happen. So that was what I wanted to say just to introduce the issue, and now I hand back to John.
Thanks, John. So as John was saying, there is a group of social scientists working in Europe at the moment on mobilizing the social sciences against infectious diseases. It's a project called the SONAR-Global project, and I have to say it's led by Tamara Gilles-Vernec, who sadly couldn't make it for this meeting, so I'm giving this presentation on her behalf, and she's based at the Institut Pasteur. So in terms of partners, so it started off, I think we were 9 partners at the start, but we've just extended, so that the project was extended for a period to do some COVID-19 work. And now there's multiple partners in the project. And it's really nice to see now we've also got partners in the West and Eastern Europe. As John was saying, that's really important to build up this capacity, this social science capacity. I think another important point is that the heart of the project is carried out by anthropologists, and I'm not an anthropologist, I'm an epidemiologist, and I've actually had a really nice journey working with them and learning a lot from them, and hopefully you'll be able to learn similar lessons via this session or other sessions. So our first activity was to publish a short letter in the Lancet where we announced the creation of this social science network for infectious diseases. And I think it's important also to say that we've got to focus on vulnerability assessment and community engagement. And as I said, more recently, we've moved into, as the SARS-CoV-2 epidemic emerged, so we've adapted and we've actually created a work package that's working on this, on SARS-CoV-2. And if you want more information about the project, there's the website, SONAR-Global.eu. And there's also a nice little film about the project if you want to see that. So there's these two themes that run through the project, and they'll run through the presentations that are coming after me. And there's the vulnerability and community engagement. And we did a social science literature review on both topics, which is published in the journal in Science and Medicine, I think. And so we review what factors are important for community engagement, what factors are important for vulnerability, and the link between the two. So that we do have various other activities. So there's a network of social scientists, there's the development of educational tools, which are on the website. There's the implementation of the vulnerability assessments, the development of community engagement. We also make policy recommendations, which is important. And so interestingly, our initial focus was on measles, vaccine hesitancy in Ukraine, and antimicrobial resistance in Bangladesh. And then as in the beginning of 2020, as SARS-CoV-2 emerged, we switched over to SARS-CoV-2. And Anna will be giving a presentation about that, Anna Maria Volkmann. As I said, it's mainly anthropologists, but there's a desire to work with epidemiologists and a wider community. And that's the reason why we're giving this presentation at escaide. So if you want more further reading about the work that's being done, or the theoretical basis of our work, here are a couple of references that you can use. And finally, I should thank the funders of SONAR-Global. The next speaker is Anna Maria. She's going to give you some examples of the work that we're doing.
Yes, thank you so much, John. And I actually have shifted the presentation a little bit, so I will not be presenting that much on SONAR-Global work, because I think we can then discuss that in our actual discussion afterwards. So I just wanted to give you a couple more teasers to kickstart the conversation later on, but you will see what that looks like in a second. So I actually will be talking about two types of vulnerability assessments, one emerging from the Cities Changing Diabetes program, and one then, of course, John, as you were referencing, the SONAR-Global project. Myself, I'm a medical anthropologist and a health psychologist, and I will focus initially on my in my talk on presenting a couple of key insights around vulnerability assessments. What do we actually mean by that? What are they? And again, the idea is really to drop a couple of nuggets that we can then pick up on later in our discussions. So please follow me. Here are the one of the key points that I wanted to make before we get deeper into our conversation was really around health, vulnerability, and risk. What do we actually mean by those terms? Because well, both terms can be a bit of a black box, especially when we're talking about these things from different points of views of different disciplines, whether that's anthropologists, or epidemiologists, medical staff, and caregivers, and so forth. So vulnerability, very much a black box. A lot of people use the term without defining it very clearly. I have to struggle. There we go. So different people, different meanings. We can talk about, and this may be most familiar with our audience today, biological and physiological vulnerability. For example, risk factors for diabetes, overweight, high blood pressure, and so forth. But then, of course, there's also emotional, psychological vulnerability. This is what we look at when we do our risk assessments, and when we look at vulnerable populations from a research perspective. Is this person of young age, immature, has mental health impairment, and so forth? Socioeconomic vulnerability is someone living with financial disadvantage or is isolated, and so forth. And then, of course, something that is being more and more focused on in my corner of research, cultural vulnerability. Are there certain, what we might term, non-normative habits or customs that make people vulnerable in their everyday life? And so one of the things I just wanted to emphasize for today, we within the SONAR-Global project have, and I intentionally put here, a working definition of vulnerability. This means being in a situation of a meaningful period of time in which a distinct set, and I put cultural, social, social and biological risk factors, but we may also add political, geographical, and some others into this. But when those come together and make it more likely than not that somebody actually experiences ill health. So this is very much focusing on health and well-being when it comes to vulnerability today. How do we identify those distinct factors? How do we understand the compounding effects? How do we take into account resilience? It's not necessarily the flip side of vulnerability, but it certainly belongs into that conversation. And how do we then also perhaps identify existing coping strategies and nourish them, strengthen them to combat vulnerability? So as you alluded to, I'll be talking about the vulnerability assessment. So I just want to give a little bit of background to that. We have in this vulnerability assessment that we've developed 3 data collection methods. Standard demographic survey questions. These are always obviously the first starting point with any assessment. At the end of the assessment, we have something we call ethnographic observations, and I'm happy to talk a little bit more about this later on. But the core of the assessment is really an interview protocol. This is something that we've been structuring and we've been working with for the past 9-10 years. And it follows roughly the same layout. The interview protocol explores in depth through this guide the use of specific formal services, what is there in terms of healthcare provision, what are the barriers, why do people use things, why don't they, and so forth. Then we look at what the community looks like. In other words, what are the kind of social networks in place that perhaps facilitate resilience, that provide some structure, help adaptations and so forth. And then of course we have the vulnerability domain, which looks specifically at external and internal stresses and again barriers to health and well-being. So at UCL, we've been working with this, and David will continue and pick up from me and talk a little bit about this kind of first large-scale vulnerability assessment that happened in 2008 in collaboration with UN and ASEAN to look at the impact of Cyclone Nargis. But since then, we've really been developing this protocol further, and we have started in 2013-14 developing the same protocol for use with NCDs. And then since 2015, this has been actually used across the Cities Changing Diabetes program, and initially in 5 cities, and it's now including 40 cities around the world. Not all of those actually implement the vulnerability assessment, but a lot of them do and build on the work. Since then, we've developed various variants. One of the variants looks at health in people with migration backgrounds. This was piloted in Bochum in Germany. Then we look at infectious diseases. Of course, we have a whole plethora of assessments in that focus area. Antimicrobial resistance, vaccine hesitancy, and of course, most recently COVID-19. Those are all SONAR-Global vulnerability assessments. So very quickly, just to get us started for the discussion, so 2020, we started with the SONAR-Global VA in 5 European partner cities, plus Bangladesh and Uganda, and I can talk about the history of this in our discussion. But the focus area of this is, of course, COVID-19, and up to today, we have about 788 assessments, and there are going to be a couple more, I think, over the next 2 weeks across these 5 sites in Europe. Then we have the Cities Changing Diabetes vulnerability assessment that started in 2015 and has been implemented, as I mentioned, across our global partnership program. That focuses on type 2 diabetes and overweight and obesity specifically. We have actually more than 1,000 assessments with that program, including full assessments and abbreviated and linked methods that are part of the overall protocol. As a result of those vulnerability assessments, we actually identified specific cultural and social factors that come together that create vulnerability to diabetes specifically, and including what we call the cross-cutting factors of time poverty, social isolation, and mistrust. And I just want to speak to those 3 very briefly in an example. I get to that in a minute, but I just wanted to emphasize that as part of our protocol, we always advocate for local adaptation, and this is really a key to this. So we have our global protocol that is locally adapted to prioritize local needs. And then we have, this is also really important, activities and strategies that these vulnerability assessments be embedded in community engagement through stakeholder dialogues and so forth. And John, I think you and your team have been fantastic with that as well, so we can discuss that a little bit later on. But one example I want to give us just for the discussion is in Houston and Texas. And as you know, I was just talking about these 3 cross-cutting factors: mistrust, social isolation, and time poverty. And one of the strategies that we developed through the CCD program in Houston was actually an initiative that aimed to combat or work with these 3 factors at the same time. And so rather than trying to implement new education programs, the strategy here was to go through houses of faith, faith organizations, because those are traditionally places where people actually have faith, they trust the people that are involved. They go there anyway, so we're not adding to their existing time poverty. And of course, they can strengthen or mitigate social isolation as well. So just a quick kind of example for how we try to translate research insights from vulnerability assessments into action. And I think David has a very interesting and exciting example also to give, so I'll stop here.
I'm going to take a step back, as Anna mentioned, to 2008 with the work that we initially did with the United Nations, because it was the first time we attempted to do this at scale. And it was also the first time that we attempted to integrate qualitative and quantitative data directly in an emergency situation. And I want to argue in the few minutes that I have against the idea that we should separate the quantitative and qualitative data, and also indicate the utility of ethnography for epidemiology. You may remember at that time, the cyclone hit in a very short period of time. There were, we don't know how many fatalities, 140,000, perhaps 200,000. There were almost 1 million people displaced and almost 500,000 people made homeless. It was a situation that was quite difficult, not only environmentally, but also socially and politically. And things had to be done quite quickly. The starting point for this was a large-scale household survey, which cannot be done quickly, which took place in 108 communities, which you see here on this map, showing the course of the cyclone. The red line indicates its course. And the idea here was eventually to try to gather quite a bit of data on the impact of the cyclone on people's health and well-being, and also to understand patterns of migration as it related to people who ended up in refugee camps and elsewhere. And the idea was to try to be as systematic and comprehensive as we possibly could be. Now, as we went along doing this, we began with this household survey. Eventually, we did almost 3,000 of these surveys, involving a relatively large population of 13,000 people. But we wanted to do this in such a way so that we could actually simultaneously engage in qualitative work on the ground. And the question is how to go about doing that. We started out, of course, with the well-known categories of vulnerability that are familiar to anybody that works with women and children and child protection in emergency situations. But we wanted to see how these played out on the ground in a particular way. So instead of simply adding more questions to the household survey, what we did was we took the household survey and we attached a data filter to that, which you see in this slide, in which we could pull out examples of each and every one of those known categories of vulnerability, so that within 2 or 3 days of the beginning of the work, we were able actually to go out and start to do work on the ground to see how those categories were characterized and to see actually if we got things right. It turned out we got things pretty much right, but there were key categories of vulnerability that only emerged through this kind of work. And of course, what this meant was, though we could not tell at the very time of doing that work what percentage each of those, what we call case definitions of vulnerability, might be as it relates to the larger household survey data sets, we eventually were able to do that because these were linked quite directly. So very quickly, just to give you examples, we had case definitions where you had a household in which the main carer is a grandparent, and we had examples of that we could, this is a summary, of course, of what it ended up being a 1 to 3 hour interview, but we could actually identify those and try to characterize them. But we could also see how complex case definitions could be made of multiple risk factors, which indeed compounded one another, making it very difficult indeed for people to manage and to indeed to have agency over their lives and in any way affect their health destiny. And indeed, we discovered through this process that there were actually new case definitions of vulnerability, which I can talk about in the discussion, that were not recognized in that initial list, meaning that the utility of this integrated mixed methods approach was concretely demonstrated to the extent that in our post-Nargis periodic review, we were able to actually use those case definitions to highlight the overall needs of vulnerable groups, and indeed to help in the application of the 88 million dollars of donor funds that went to assist those populations. So I'm going to stop there and say thank you very much, and look forward to the discussion.
Thank you very much, David. Take you to some other places. My name is Ruth Kudelek. I'm from the Medical University of Vienna. I'm a medical anthropologist, and I have worked with WHO and other organizations in the West African Ebola outbreak. In the last couple of years, there has been a growing demand, as John said in his introduction, to deploy anthropologists and other social scientists in health emergencies. And anthropologists have been hired by larger organizations such as WHO, UNICEF, ECDC, Doctors Without Borders, and many others. So I want to pose the question, what makes anthropology so useful in health emergencies? I would like to give you some thoughts on this, and let us discuss a bit later in a bit more detail. So while epidemiologists actually look at the distribution of disease, anthropologists tend to look at how and why. We, or anthropologists, social scientists, we try to understand on the ground realities. So how are people living with the disease in day-to-day life? How do they understand the disease? What in terms of transmission, and also in terms of the cause of the disease, for instance? How do they have access to health services? What are the pathways of infection? What are the social dynamics of disease transmission? How do individuals get infected, actually? And how do communities prevent disease transmission? So these are all issues that we are asking in disease outbreaks. Specifically, how do communities also enable public health efforts, and how and why are they probably hindering efforts? Social scientists are also asking to include the perspectives of communities, as my colleagues before me have said already, that how they are dealing with the structural barriers in certain areas and in certain emergencies. We are trying, social scientists and anthropologists are trying to make interventions more culturally appropriate, meaning that we are trying to ask ourselves, how are certain issues like contact tracing, for instance, or active case finding, how are these activities performed to guarantee the acceptance of the local populations? So all in all, I think what we are trying to do is to contribute to humanizing the response to health emergencies. And I would like to give you one example that has been very important for me, and I think one of the reasons why I have been deployed by WHO to the West Africa Ebola epidemic in 2014 to 2016. So this example is about community resistance. Community resistance is a term very often used in meetings of, for instance, incident management systems or other government or non-government emergency systems. But community resistance is often not obvious. It's something that can be very subtle, and it can lead to a low but persistent resistance. So, for instance, hiding of sick people, suspect cases not wanting to be found, affected persons seeking informal medical care instead of formal medical care in Ebola treatment units, for instance. So this resistance is very often dismissed as a kind of stubbornness or as being part of their culture. And it is often due to inconsistencies in information that people receive, and also due to distrust in government institutions, as Anna has also put. So when we say communities resist efforts, for instance, in quarantine or isolation, we see what is happening, of course. Communities do not comply to quarantine, they do not cooperate. As anthropologists, we are asking, why is that happening? So in West Africa, for instance, we came to know that there was no food and water provided for families in quarantine. Persons in quarantine, they would lose their jobs because they were not able to go to the market, for instance, to sell their vegetables, and they received no compensation for this loss. And very often we could see that families in quarantine are stigmatized, and by other families, but also by communities. So I think what anthropology is really contributing is to enabling affected individuals and communities to follow measures. So I would like to end with a citation by Stelmach et al., who are saying that anthropology can provide insight on why public health interventions succeed or fail, the gap between what is planned and what is realized on the ground, and the unintended consequences that may result from that. So hoping to kick off some interesting discussions with you. Thank you.
Thanks a lot, Ruth. Thanks a lot to all the speakers for these really insightful presentations. And I think the people listening to this session, I mean, if you're at escaide, you very often work in Europe, but you also work outside of Europe or in Africa or in Asia or Latin America. So they'll really appreciate these different examples. So if you have questions, you can send us questions in the chat, and we'll answer those. And I think a lot of people will be wondering about. So we've got a lot of practicing epidemiologists or medical epidemiologists, and they see these new approaches. It's something we discussed a lot in SONAR. Is we really like to when the project's over, to leave with some tools, and maybe each of you could talk about the tools that are available out there for epidemiologists, either for them to use them themselves. It might be that you should actually work with a social scientist or an anthropologist to do the data collection. So I don't know who would like to start on that. I know that David and Anna are developing loads of tools in the diabetes sector. I don't know if you want to say something about that, but because I think our audience really appreciates having access to tools. But I think that's operationalizing things. Yeah.
Yes, John. Let me just jump in there, and I think you've just started to touch on a really interesting theme that, as you say, has been very much ongoing throughout our collaboration across SONAR, and that is how do we involve people from other disciplines in a meaningful way? And I think one of the key points here is also that we can contribute something, but we would also very much invite others to contribute as well, because we can't stem everything on our own, and nor should we, nor do we want to. And I think what Ruth was actually explaining beautifully is this. Is the what and the why. It's always this question. I think that where social science can be really useful is really diving deeper into the why. And as you alluded to, we have tools. We have data collection and analysis tools, one of them being the vulnerability assessment, but we also have some other data collection analysis instruments that follow the same kind of thinking and that have similar ideas behind them, that are not as resource intensive, because a lot of qualitative research does require a lot of resources. It does require experience. And so, John, I would very strongly argue that for bigger projects, or for projects that really need deeper insights, such as Ruth was describing, or what David was saying also, surely a collaboration with social scientists and epidemiologists is fantastic. But there are also tools that epidemiologists might want to explore on their own, where you can just have a slightly different approach to a research question, and a lot of those can be accessed actually through the SONAR-Global website. There's a lot of training materials on there. We also always offer workshops. A lot of our colleagues from some of the other areas have done a tremendous amount of work putting together training curricula for non-social scientists as well. So I would actually ask people to use that as a first stop. For sure, but I'm sure my colleagues have other points to make as well. So,
sure, I'm happy to jump in there, John, since you elected to point this in the direction of Anna and me. I want to make 3 points really quickly. One is to just to emphasize a point that Ruth and Anna both made, which is that our focus is not simply to engage in a qualitative assessment of what we see happening on the ground, but actually to try to bring lived experience to the level of evidence. That is to say, how do you, on the ground, actually make sense of vulnerability and resilience, and how do you actually scale those things? So for example, in the Cyclone Nargis incident, I alluded to the fact that there were other case definitions of vulnerability that emerged. One of the slides I showed that I went through very quickly was a picture of a refugee camp in which immediately a temple had been erected in its center. You may not have noticed that, but the point being that temples traditionally are places where rice is tithed, and in emergencies where people go for emergency rations in the traditional cultural sense. Now, of course, as many people who study Southeast Asian religion know, young girls are allowed into temples, but they're not allowed into temples when they reach puberty. They're not allowed into monasteries. And it turned out that the most vulnerable group in Myanmar were actually girls reaching puberty. None of the categories listed specifically on the UN list, and which also actually helps us to understand some of the challenges that are faced in that region of the world with child trafficking. In the case of SONAR-Global and the COVID-19 assessments, we are trying to scale our evidence in 3 of the participating countries, in France, Germany, and Italy, and indeed specifically in Italy already. Those assessments are being used to have an impact on public policy. So I just want to use this moment to emphasize that we're not offering necessarily a different perspective on things, but we're trying to find ways of integrating what we do with data sets that make sense to people. The second thing I want to say very quickly is that one of the advantages to carrying out the assessments is something I alluded to in my presentation, which is it allows us to see how risk factors compound one another. In most RCT work, randomized control trials, we're always parsing information and looking at specific links, but very rarely do we look at the compounding effects in real time and how the compounding effects push people beyond the threshold where they're able to become advocates for their own health destinies. And we have lots of examples of that, which we can take up later in the conversation. But I think everybody understands the importance of looking at these compounding effects in real time. So those are 2 things that that our assessment strategies try to work on to bring what we do as social scientists within the framework of what others do, in particular epidemiologists. Ruth, you had your hand up. Did you want to jump in?
Yeah, very briefly to jump in, David. I think that has been really vital to the issues you have been mentioning. I think another issue that is something that is connected also to concrete solving of certain issues is to have participatory approaches and to have people participate in making of solutions. There have been quite some interesting, or there are quite interesting methods of using of including people into measures. So one of that, for instance, focus group discussions. That might sound a bit for epidemiologists probably a bit flimsy, but it's something that is really very much to the point and very much dealing with the life world of the people, like really asking members of focus groups of what they think about certain measures, like how do we make sure, for instance, that people who are sick in an outbreak, that they report to the authorities, for instance, that they don't hide, that they are calling the phone numbers, and in getting this buy-in by the participants, it is also, these measures are also much more useful for them, and they are also much more useful also for the public. So just to add on that.
Ruth, I'm going to jump right into that again, because I want to go back to the example, Anna, that you brought up about faith-based organizations in Houston, because one of the things that emerges in the community engagement section of the vulnerability assessment, where we're looking at social capital, is we're trying to identify who are the stakeholders, formal or informal, in any setting, and actually to see how their actual ability to function is fueled or inhibited locally. And here the kind of focus group activities that Ruth is talking about really do help us better to understand the go-to people, and how when communities are under stress, there are oftentimes inequalities get exaggerated, and it becomes quite difficult to identify some of the more vulnerable populations, because these people don't have agency oftentimes, and those who represent communities do. So this engagement part is really, the dynamic and reiterative nature of it is really critical to successful interventions. And I see Anna and John both have their hands up, so I'll stop there.
Anna, maybe John can talk, so everybody's has their turn, and then you can take over from there. Go ahead, John.
Okay, thanks. No, this is an extremely interesting discussion, and I'm as an ECDC employee, I'm thinking about this from a sort of EU perspective, from the point of view of where we work, which is trying to ensure that the data that is available for decision makers is actionable and accessible and understandable for them. And I think this is one of the big challenges that social scientists face, because a lot of the work that we do is, in a sense, rather, or it can appear to be quite theoretical, and it can appear to be a little bit difficult for people to grasp. So to me, one of the key things that we need to bear in mind is, how do we actually cross that bridge? How do we present decision makers with material which they can say, ah, I get that, instead of saying, I don't really understand what I'm supposed to do with that. Very interesting, but, and there's the big challenge. And I think your example, Ruth, from Ebola is a really good one. In a way, the Ebola outbreak provides almost the sort of best example of how social science and anthropology really played a key role in addressing the problem at its absolute root. Because especially in the beginning, when it was a lot of people, when the amplification of the outbreak was through unsafe burials, there was a lot of misunderstanding from the international community and from the people who were running things at national level as to what was going on. And as you said, community resistance was the key. There was a perception that the community was being difficult and not complying with what was needed. And the reason was there was a fundamental misunderstanding about burials and what burials meant for the community. And the anthropologists came in, made it very clear that you need to do a safe burial, you need to do a proper burial from a cultural point of view in order to allow the spirit to leave and in order to allow the community to then move on. So this wasn't recalcitrant, difficult people. This was people doing what was really important for them. And anthropology showed that very clearly. And once that recognition had really seeped through into the decision makers' awareness, then the whole program started to change. So I think in a way that's a really good example, but it's a rare example, because it's rare that you get such a clear-cut reason for resistance. And I think what we have right now is what is often termed as vaccine hesitancy, or perhaps you could reframe it as low levels of vaccine acceptance, which is, I think is probably a better way to put it. And we don't really understand very much about it, actually. There's a lot of the talk is not very nuanced. A lot of the talk is of, again, recalcitrant people who are being difficult and not really actually understanding what we need to do and what's best for them, and all these same sort of argumentations. And actually, we're clearly not meeting these people where they are. And so I think this is, to me, this is a big opportunity for social science really to move in and actually properly understand in a way which we can put into action the impact of that. So I just wanted to put that across there.
Anna, maybe you can also say something when you answer, something about turning the social science findings into policy, how that works, or what your experience has been.
Yes, thank you so much, John, for that. Both Johns, actually, because I was about to say something with the SONAR project. We actually are getting some incredibly great insights into vaccine hesitancy and all of those things that drive certain behaviors around the pandemic. However, those are the findings from our partners, so I would not want to share those at this point. But please, we will be, obviously our partners will be talking about them, we'll be publishing them. There will be a lot just in the next few weeks. We just about missed that, I think. But there will be, I think, some interesting insights coming forward from SONAR very soon around those issues, John, that you are alluding to, in particular around the social, the cultural drivers of certain behaviors around COVID-19. But I just wanted to give one. It's a bit of an exotic example, but I also very much like it because I think there's a lot of strength in the social and the qualitative sciences around exploring not just testing theories, but also embracing solutions that may already be present in the community. And one of those things I was just reminded of as I was listening to you all was actually when we did a vulnerability assessment in Mexico City around, so this was diabetes again, but there was a lot of conversation with our participants around what can we do to improve exercise or physical activity levels, and of course health and safety is a huge and significant concern in certain areas in that particular setting. And we learned through the vulnerability assessments that some communities that actually come up with a pretty clever way of ensuring their safety when they were out exercising. There was a group of women in particular that had organized themselves to meet regularly in a Walmart parking lot because there were security guards there, it's well lit, there's always someone there. And so they found their own solution. And so this is just one little example for how findings through qualitative research can actually provide really good solutions that don't have to be very costly. Programs like this could easily be expanded. They could easily be supported without much, resources, but they're already there. And so I think that's one other argument that I would like to make for why qualitative research can be so important. It's just one little example, but yeah.
But didn't you also find for diabetes in Moscow that people were not aware of the services? And then that was also a very good example where then all the policy recommendation was, well, get people to know where the services are available, and, you know, get that message out. Yeah.
Exactly, and in fact, this is particularly in Moscow. There are some very good programs already available, but people were not aware of them. Particularly also because there's very little in that particular research population that my colleagues were working with. Very little social interaction, so there was no kind of word of mouth, no transference of knowledge around that. And so something that was already there that was actually good, that had been taken up successfully by some people, was just not used as much as it could have been. So yeah.
Ruth, do you want to say something? And then David, go ahead, Ruth.
A very short example of what can be actionable. When I was in Liberia during the Ebola outbreak in 2014 to 2016, I was one day I was called by one of the epidemiologists to a community in Monserrado, which is the larger kind of Monrovia in Liberia, and I was told that people are blocking roads there, and I was asked if I could help. And there had been a community death, and the burial teams, they wanted to bury a body, and they had been met by angry villagers, and they were actually, villagers were throwing stones on the burial teams. So on my arrival, we were two, a colleague of mine, a male colleague, and myself. We went there to the area, we left the car a bit outside of the area and walked in there, and we went, I don't know, 20 plus angry or so men. My colleague talked with them in a very soft voice, and we asked them what happened, and they complained that whenever someone died in the neighborhood, they were living near a graveyard actually. So whenever someone died in the neighborhood, the corpse is brought in an open pickup, and the body is in a red body bag, and this body is accompanied by 4 Red Cross workers in full protective, in full PPE. And because the bed is road, they have to leave the car and go with the body, red body bag in between them, and walk through the village actually to get to the graveyard. And the village is not informed about that. They are walking through the village when the people are having their lunch outside, when the children are playing on the ground there. So no wonder actually that the villagers were angry. And a very, very simple solution to that is inform villages when something like that is happening, and informing the response teams when something like that is happening. So sometimes very, very great questions and very, very simple solutions.
Go ahead, David.
Yeah, this is really a very interesting conversation. 2 things that jump out right away. And John Kinsman, I'm very glad that you brought up the idea of sustaining our concern over these issues as the, for example, in COVID-19, the pandemic changes over time, and people's personal, perhaps, views about it also shift. This is, I think, a really, really important point. In our vulnerability assessment in Uganda, we actually entered the field based upon the sorts of things that Ruth was talking about, initially trying to look at Ebola. We ended up in the field in January 2019, which meant we were on the ground actually doing field work as COVID-19 emerged. And I am fairly sure, and we should know, and I think we're right in saying this, that we were the only social science group that actually did systematic field work on the ground, face-to-face, around COVID-19 once the pandemic broke out, because we were there before it actually happened. And our colleague, David Mafajiri in Kampala, much credit to him for actually getting out into the field and doing this work. So the idea of not just having a just recovery, but also what does just preparedness look like is really a critical dimension of this that I think we need to bear in mind. The second point is and I was really interested, Anna, the focusing on isolation, mistrust, and time poverty. That is simply not having enough time because of rather more compounding things that limit your ability to do things. Because typically we focus in our views of the social determinants on things like economic barriers, educational barriers, so forth, family background, those sorts of things, which are all critically important. But what really has surprised us in our vulnerability assessment work is how much these are actually the foundation of these are to be found in things like social isolation, mistrust, and time poverty. And indeed, we found, for example, in some of our work in China, that social isolation by a factor of 3 was more important to people than even health equity. So what one can learn by this kind of work, and when one learns it, is really, really critical. And also it undermines some of our stereotypical assumptions. So to look at this from the other way, for example, in Houston, we assume that people are hesitant because they don't trust government, will not take a vaccine for that reason. Houston decided to offer people $100 for the first shot and $50 for the second, And the uptake of COVID-19 vaccines skyrocketed. And it wasn't because people were suddenly trustful or they needed $100 necessarily. It was because $100 allowed most single mothers actually to hire babysitters so they could go and get the vaccine. So these compounding barriers are really critical in understanding and modifying our taken for granted assumptions about what things like vaccine hesitancy are all about. John, I see you have your hand up. I'll stop.
Thanks. Well, it actually really feeds in from exactly what you were saying, because I think one of the key assets of qualitative research is that it allows you to learn things that you didn't know. And it's with a survey, you know what you want to know, and you're asking very clear questions, and you know you're going to get results on these issues. Whereas with qualitative research, you're going into a situation and you're essentially telling people to give you the answer to the question that they have, which may not be the same question you have. And thereby you're getting exactly these answers, whether it's Ruth's example from Liberia or your example from Houston. And just to go back again to this issue of vaccine hesitancy, which is really, really the sort of salient issue of the day. We talk about vaccine hesitancy as if it's a simple concept in many ways, and it's oversimplified and not nuanced, as if it's people not believing that the vaccine is a good thing. And exactly what you're saying there, David, more often than not, and this is the case, we're seeing it also very much in European settings, it's not about people who don't believe in the vaccines, it's about structural issues that inhibit them from accessing the vaccines. And therefore, if we use the term vaccine hesitancy, it's essentially what you're doing is victim blaming. And it's the wrong concept in this kind of discussion. So I think this is where qualitative research and social science can really shed light on an issue which is telling us something that we didn't know, and thereby providing us with a possible answer which could really, really help us out in this situation that we're in at the moment.
Completely agree.
So John, that's really important, this putting the blame on people who are not getting vaccinated. So do you have a better term than vaccine hesitancy?
Yeah, we should be talking about vaccine acceptance. We should be flipping the whole thing around. Yeah. But vaccine hesitancy is inherently a negative framing. We should be framing it as vaccine acceptance.
Yeah.
Sorry, it's as simple as that. And every time someone talks about vaccine hesitancy, I can't help it, but I sort of feel something and I try and stop it. Here's another example.
And when you raise this point at ECDC and other European institutions, are people responding to that, or is it?
Yes, they are. But definitely, I've noticed people are quite intrigued by that whole thing. But then it's because vaccine hesitancy is a term we use, it's very easy to slip back into it. It's rather like, interestingly, with social distancing at the beginning of the pandemic. We also had discussions here, and I said it's not about social distancing, it's about physical distancing. It's exactly the opposite of social distancing, which is what we want to do, because you want to have social contact but maintain physical distance. And so therefore the word has stuck in many people's minds, but more and more people do use physical distancing. So it's the same sort of thing. A word gets set in someone's head and it's very difficult to remove it and put in actually what may be a more sort of correct term.
So how can we correct this?
Time, effort. We keep on hanging on about it. Gradually it will change.
Yeah.
Gradually it will change.
So we're gradually coming to the end of the session. I think we've got 2 minutes left. So I just wanted to ask, so if somebody in the audience is interested in social science, infectious disease, vaccine acceptancy, or doing a diabetes study, or doing a study on Ebola, so can people reach out to everybody? Is that possible, or how would that work? I was also had this wild thought that John, if you meet somebody, one of these EPIAT trainees who wants to do some social science work, we'll send them our way and we'll support that person. Fantastic. I see everybody's nodding their head, so I think we've got an agreement there. So,
and John, I think if people go to the website, they can find all of this really quite easily there.
Yeah. So we would very much welcome that, interacting with epidemiologists, medical epidemiologists. Does Anne want to say something?
Yes, I would like to say I think we've had this conversation amongst us, but I also really want to extend that invitation because we are really curious also to learn about ideas that epidemiologists might have on how to collaborate with us and how to build on our results, because that's really where we see a lot happening in the future. So we would, I think all of us really welcome a dialogue.
Okay, well, I'd like to thank all 4 speakers, and I'm hopefully people will approach us, and we will very much welcome that, and we hope to work with epidemiologists and medical epidemiologists and whoever approaches us on social science infectious diseases. Thanks very much, everybody.